happy Friday, everybody. People are still trickling in, so I wish you another happy Friday, and we'll count the number of happy Friday. Oh, just two. Okay, I'm prepared to deliver bad news. And I've been told that the best way to deliver bad news is to say you have bad news. That counts as the warning shot. Bad news, it's Rabi. It's Rabi Sine Reza. Reza is on service and is 1000% committed to his patients. So he's not here today. That's the bad news. That's the devastating news. We cannot recover from it, but we will try. How? Two things prepared for you. One last minute, as I will tell you in a moment, and one very prepared. I'm going to introduce you to a Lebanese delicacy. It may be not strictly Lebanese, but Fernand will vouch for me. So this is called za'atar. Oh, wait, hold on. Damn it. This is called za'atar. You may have heard of it. It's very popular. It is a Lebanese spice on the most amazing pita bread made by that lady behind the fridge over there. Hello. Oh, no chance. She's gone. My mom is in town visiting, and hello, say hello. Just say hello.
Hello, everyone.
Okay, great.
Yeah.
Okay, thank you. She says hello, everyone. She's very busy right now. She just said, wait, how come no one responded? It's okay. Hello. There you go. There's Travis is saying hello. Anyway, moving along. The other thing I wanted to let you know is our dear friend Anne-Marie presented an absolutely, yes, I am, an absolutely incredible case yesterday, and is here in a hammock to reflect. In the meantime, please, if somebody has a case, please volunteer to present it. We cannot do it without you. So if you have a case, please volunteer to present. Oh, Ori has a case. All right, fantastic. So Ori, I'll have you introduce yourself in a moment. Emery, take us through the journey of yesterday.
Okay, so yesterday I presented a case about a patient presenting with nausea, vomiting, and tachycardia. The background of the case was that had recently been hospitalized for osteomyelitis and necrosis, status post amputation of the foot, had completed antibiotic treatment, and then came back for this persistent nausea, vomiting, and tachycardia. So first we're trying to figure out, is there some sort of infection? Is there some sort of sequelae of the hospitalization, like pulmonary embolism, things like that, or kind of where does this nausea and vomiting center? Is it in the abdomen or something else? But then further history, this had actually been quite long-standing for the past few months. And then some of the pivot points of the case were that eosinophilia was also seen, that had also been present on last hospital admission even prior to antibiotics. There was no signs of wound infection or anything like that. And ultimately, a morning cortisol came back at 1.2. Cortisol has a circadian rhythm, but generally a morning cortisol less than 3, especially, is highly suggestive of adrenal insufficiency. Received a cortisol stimulation test that showed an inappropriate rise. It should rise up to 18 after the stimulation test within an hour, and it only rose to 7.5, concerning for adrenal insufficiency. The interesting part about this case is there was no hyponatremia, no hyperkalemia, some of the other labs that you'd associate. And then there was no hypoglycemia, although this was confounded by diabetes, and so it made it difficult. And so then we're trying to figure out what's causing the adrenal insufficiency. And adrenal insufficiency, you think about primary, is it coming primarily from the adrenal gland itself, which generally, if it's from the adrenal gland itself, you get concomitant aldosterone deficiency, which is associated with that hyperkalemia that can occur between 30 and 50% of cases as well. And then, is it secondary? Is it coming from the pituitary? All the other pituitary labs were stable, and we didn't have a clear reason why, and no other CNS symptoms. And then one of the most common causes is actually suppression due to exogenous steroid that someone is taking, whether it be prescribed or not prescribed. And in that case, you would not see kind of the other electrolyte abnormalities necessarily. Sometimes you might see mild hyponatremia depending on if ADH is associated, which sometimes you can see a rise, but you wouldn't see all the other abnormalities. So further history showed that she'd actually been taking an over-the-counter arthritis medication available in Mexico that had bechamethasone in it, which was the equivalent of about 6.25. She'd been taking it for several years and then stopped it abruptly after she heard from a healthcare provider that it could be bad for her. But then since then had these symptoms, but it took a lot of like history and questioning to figure that out. So I just thought it was interesting, just kind of putting things in context, but also just making sure that you're really discussing with patients and getting a good over-the-counter history. That is my reflection.
Absolutely brilliant. I'm very envious of the hammock and very envious of the sun, and I'm so inspired by just how effortless that was and how much rich learning points there was in that case. Thank you so much for presenting it yesterday, and then to add to that, reflecting on it today. Thank you, Anne-Marie. I just, while you were talking, I saw that folks had mentioned that there was some sad news today. Fernand and Kushal mentioned some very sad news, and I just saw on Twitter too that Francisco Marti, who you may know is a very prominent ID doctor. I didn't know him personally, but made a tremendous impact on Twitter. Actually passed away. It seems from an accident, as what's described, which is a tremendous loss, I imagine, for the local community and the people he touched on Twitter. So I'm sure people who know him more can say a lot more, but I'm very shocked and surprised to hear this news. And if you have more to reflect, please do so in the chat. Uri, welcome. Long-time listener, first-time caller I saw. Please unmute yourself and tell us more about yourself.
So I am finishing my MD PhD at Columbia in New York, and I'm matched at UCSF for neurology residency.
Oh, amazing.
This summer.
Incredible. Congratulations to coming to the best city in the country. I wasn't going to be controversial and say in the world, but I'm a little controversial. Tell us more about yourself. What do you do outside medicine?
A lot of science, and I have a girlfriend and a stepdaughter.
Incredible.
She's an OBGYN, and I garden, and that's pretty much it.
Garden. Okay. What is the hardest plant that you've had to raise?
Honestly, I grew beets last summer, and in my New York City apartment, I'm like a little planter, and they were just very dramatic. So if you water them in the morning, they would stand up with their leaves, and then by the end of the day, they would just be over and be like, "We need more." And then you pull more water, and then they kind of rise up. They're very fickle.
That's incredible. At the end of the day, that's just crazy. Wow. You know what? I'm gonna unprompt you ask a dear friend of mine to tell us a pearl that she taught me. Valeria, are you there? When you heard Ori say beets, what came to mind? Please tell us. Valeria had an incredible tutorial. She might not be there. I don't see her unmuting herself, but she taught me that beeturia, when beets make it into the urine, is a sign of is a sign of increased iron absorption in the GI tract. So a fascinating mechanism that hopefully somebody can get into Twitter, but reflects either iron deficiency, causing a lot of GI absorption, or hemochromatosis, which is pathologic iron absorption. But somebody hopefully can link that in the chat. Okay. Ori, I am so excited to nerd out with you and go through a case with you. And I'm sure that a case presented by yours truly, you'll probably stump me, but I ask you to be prepared because I will probably be your attending in 6 to 7 months. So be kind to me, okay? But I will not do this alone, and we'll really leverage the chat and try to highlight as many reflections in the chat as possible. So really, is all of us together. And Ori, please take it away.
Okay, so just the structure of the case. So I'll give you an HPI, then aliquot 2, I'll give you kind of the background. 3 will be a hospital course. 4 will be some pathology, and then 5 will be the diagnosis, just so you know. Okay, so this is a 72-year-old man. Oh, I'm sorry, I lost my notes. Okay, 72-year-old man. He's in the emergency room for confusion and gait imbalance. So 5 days before the presentation, he had intermittent episodes of confusion. During these episodes, he felt lightheaded and dizzy. The dizziness was worse when he tried to stand up and improved when he would sit down. When he was standing, his legs would start to shake, and this was again relieved by sitting down. Over these last 5 days, he's also had daily subjective fevers and chills, felt very fatigued, but he's had kind of no localizing infectious symptoms, and otherwise has been completely normal. There's no other sick contacts, recent travel, and that's pretty much the general HPI for this guy.
Ooh, what an incredible start. And the sense that somebody is left with in approaching this kind of problem is you're really walking through fog. It's very, very hard to be like, this is the path that I'm going to follow. And there's many reasons for that. I think the primary reason is that episodic disorders by inherently are very, very hard to solve. So when you think about somebody having transient symptoms that come and go, especially when you are evaluating them at the time when they are asymptomatic or minimally symptomatic, it becomes very hard. And what you're really trying to do, if you happen to catch them outside an episode, is to see traces of the episode on somebody. So if somebody syncopizes and comes into your emergency room and they're at that time completely normal, you're looking for the delta wave on the EKG or the aortic valve murmur that was a clue to what happened, but episodic disorders are inherently very hard. And then it's very clear that the center of gravity of this case is diffuse right now. There's signal towards the brain, there's signal towards the peripheral nerve, there's signal towards maybe cardiovascular disease, there's signal towards inflammation. And so right now it's hard to coalesce it into a neat thread. So what you're trying to do is you're trying to track everything together and try to make as much progress, but not lose sight of anything. And I think the easiest thing to reflect on is acute inflammation, and that inflammation is really in the form of fever. And so that is a world we've talked a lot about that focuses on infection, and we'll put a pause there. What does the confusion mean? The confusion Confusion is tricky because it implies that there's a problem with the brain, but when you go to the brain acutely, you often go back out the brain. What do I mean by that? When we talk about acute altered mental status, we often share the mnemonic of MIST, metabolic, infection, structural, and toxin. And the M, the I, and the T are all systemic diseases. The S is the only part that implies the brain. So when you say confusion, you take an immediate trip to the brain because the brain's perturbed, but almost immediately you take a trip back out to the world of hyponatremia, hypercalcemia, hypoglycemia, etc. So that is tricky. And then the gait imbalance ultimately says the neuroaxis is not working very well. And the neuroaxis may not be working well because of an issue with sensation, because your sensory input is compromised. It may be an issue with coordination from the cortex, from the basal ganglia, or from the cerebellum, or an issue with motor output. And so you can see that impaired balance localizes to everywhere in the neuroaxis. But the easy way you can knock out the entire neuroaxis with one almost fatal blow is having cardiovascular compromise. So if you don't perfuse your brain, guess what? You're going to be confused and you're going to have gait instability. And so that takes us into the world of lightheadedness and dizziness, which is worth withstanding, implying that there might be some sort of cardiovascular or orthostatic component to this syndrome. So if you're being truthful with your analysis, you're like, oh, I'm going to land in the brain, but often an acute brain issue lands me in the periphery. The brain is the focus of confusion, but the gait imbalance may imply some sensory or motor issues. So you're really doing that dance. And then you're like, well, wait, I can have a simple cardiovascular issue that explains all of this. So the question is, are we in the brain? Are we in the cardiovascular system? We're very likely to be inflamed. But remember, when the space is confusing, the space being the brain, the cardiovascular system, or inflammation, the time course tends to be very informative. And it's hard to ignore the episodic nature of this disease. What does episodic tell us? Here's a fun clinical reasoning pearl for you. We've talked about sudden onset before. When something starts suddenly, it's either something ruptured, something got blocked, there's a discharge of electroactivity, or there is the immediate action of some molecule like insulin causing hypoglycemia, like mast cell mediators causing anaphylaxis. So sudden, block, rupture, electricity, and molecule. Episodic diseases, especially when they begin abruptly, tend to be a subset of things that begin suddenly. So if you ask yourself, what are things that are episodic? TIA, BPV, syncope, biliary colic, renal colic, all those transient things are a subset of things that begin suddenly. And what makes them transient or episodic is they not only begin suddenly, but also end suddenly. So I have said nothing, but I'm worried about something blocking, rupturing, discharging electroactivity, or the action of a molecule. I don't know where the localization is. Is it brain or is it cardiovascular? How do you make progress? I think a neurological exam and a cardiovascular exam would be incredibly informative. The truth is, though, it's hard not to say that when somebody goes from profoundly normal to profoundly confused, that either it's a pretty bad brain problem, it's a pretty bad cardiovascular problem, or quite simply, it's pretty bad intermittent hypoglycemia. Alrighty, Ori, back to you.
Sorry, I was muted. So just quickly, this is pre-COVID, and the chat is incredible. You guys are awesome. Okay, so the patient had a notable neurologic history for a previous admission almost exactly 1 year before, where he was brought to the emergency room with days of confusion. He had a lumbar puncture, and that was consistent with a potential viral meningitis. And then it cleared up within essentially days of starting antibiotics, and that's what led them to believe that it was viral. Since then, he's had a decline in cognitive function. He stopped working. He required a home health assistant for his daily activities, and has overall had a kind of just a steady decline without any steps or anything like that. And then that led to these 5 days prior to the current presentation, where the episodes began. His past medical history is also notable for diabetes, well controlled, hypertension, BPH, gout, and some venous insufficiency. His medications are a combination pill of olmesartan, amlodipine hydrochlorothiazide, Flomax, aspirin, allopurinol, sitagliptin, metformin. And I can do his exam and vitals now, if that's good. So his vitals in the emergency room were, he was afebrile. His blood pressure was 120/65, heart rate of 84, satting 96% on room air, respiratory rate of 18. These were lying down. Standing, his blood pressure dropped to 90/50. His heart rate was 105. He was in no acute distress.
Just jump in real quick. You might have to slow down a touch for the keep up.
Hey, what are you trying to say? I can't keep up?
No, I'm trying to say that
he is good.
He's say that you are typing in the chat.
I'm flying. Okay, so the BP standing was 90/50, heart rate of 105. His cardiovascular exam was normal, regular rate and rhythm, no murmurs, rubs, or gallops. His lungs were clear. His abdomen was soft, non-tender, and non-distended. He had no peripheral edema. And now for the most important part of the exam, the neuro exam. So his mental status exam was notable for inattention. He was unable to count from 20 to 1. He was oriented to place and person, but not to time. He had a good fund of knowledge. He had no difficulties with speech. He was able to follow multi-step commands. His strength was 5 out of 5 to convertation in all muscle groups. His sensation was intact to all modalities. His coordination was normal. And his gait was described as hesitant in the emergency room, but not wide-based or ataxic or magnetic. And reflexes were normal. So do you want basic labs here? Would that be helpful?
No, honestly, I think you've given us so much to reflect on, Ori, that I'll just stop here and maybe actually even reflect on what the labs might be. But I think, honestly, the clinician is probably thinking real hard at this time, and so I'd love to think out loud with you. I think what fundamentally changed is the time course. We started with this being the assumption this is an acute episodic disorder, and we have later learned that this is actually a subacute decline. And I'll jump to the exam to tell you that the exam tells us that there's something localizing in the brain. The attention is a purely cognitive process, i.e. it is supratemporal. So we know for a fact that this person has a brain problem. And the problem lives within the brain because of loss of attention. And so how do we make progress? We make progress by marrying that with the time course. This is not acute brain decline, it's not hyperacute. The question is this subacute or chronic brain decline? Chronic brain decline is essentially termed dementia, and the most common cause of dementia in the United States and the whole world is Alzheimer's dementia. And the question is this a dementia? And I'd say there's two reasons to say that that's not the case. This patient in a year went from a highly functional individual to the individual we see before us. So calling this a dementia syndrome is possible, but it's highly unlikely. And so a good frame of reference to take is this a rapidly progressive dementia? And I'd say that that's probably the best framework for us to take. There's some, I approach that with a little bit of less tempered enthusiasm because subacute neurological problems like this are either labeled a rapidly progressive dementia or subacute to chronic meningoencephalitis. Those are the two ways that you can represent this problem. Let me show it to you visually briefly. One sec, folks, so we have a little time. So, come on. Wow, the computer is really slow today. Almost there. Okay, there we are. Travis, I'm gonna steal the screen for a second. Okay, so here we are. When you're studying the world of encephalopathy, the time course is really key, and we're not in acute or hyperacute. We are here. And there are two ways we can represent this problem, either a rapidly progressive dementia or a subacute meningoencephalitis. And how do we differentiate the two? We differentiate the two with a lumbar puncture. Implied in the term rapidly progressive dementia is that the inflammation is located in the brain itself and not the meninges. So here, the real question is this a rapidly progressive dementia or a subacute meningoencephalitis? That will make, that we can only, Travis, I'll hand the screen back to you for folks to look at stuff. That we can only make by getting an LP now, but it's hard not to assume that the prior meningeal process is ongoing right now. So in real life, I would be pursuing both the subacute meningoencephalitis hypothesis and the rapidly progressive dementia hypothesis. What is the most common cause of rapidly progressive dementia referred to tertiary centers in the United States? By far and away, prion diseases. These are things like Creutzfeldt-Jakob disease and its variants. The majority of patients with Creutzfeldt-Jakob disease will have myoclonus or cerebellar ataxia, none of which are apparent here. So that's a little bit less likely. What are the three other prominent diseases? Autoimmune encephalitis, either antibody-mediated or vasculitic autoimmune encephalitis, so things like anti-HU, MA, NMDA, a whole list of things. Vasculitis, like primary CNS vasculitis, is the autoimmune category. Psychiatric diseases actually make it up there, and the psychiatric diseases are pseudo-dementia with depression or catatonia. And lastly, the Parkinson's plus syndromes. The Parkinson's plus syndromes like multisystems atrophy, progressive supranuclear palsy, Lewy body dementia can present in a rapidly progressive manner. So if we are assuming the LP is negative or minimally inflamed, the four common causes would be prion diseases, autoimmune brain diseases, either antibody or vasculitis, psychiatric diseases, or Parkinson plus syndromes. If we study the remainder of the lay of the land, the two prominent clues that stand out to me are the history of diabetes and the presence of likely autonomic dysfunction. How am I inferring autonomic dysfunction? I'm looking at the orthostatic vital signs and seeing that the patient is orthostatic with no medications as obvious culprits, even though the patient's on blood pressure medications, they don't seem to be this prominent. And there's no evidence of hypovolemia. So if we're mapping this onto autonomic dysfunction, the Parkinson's plus syndromes emerge as a prominent consideration. Lewy body dementia, PSP, MSA, but the limbic autoimmune encephalitides also feature prominent autonomic dysautonomia. So if we're saying this is rapidly progressive dementia plus autonomic dysfunction, both of those are not foolproof yet. We don't know it's rapidly progressive dementia. It could be subacute meningoencephalitis. We also don't know it's autonomic dysfunction. It could be adrenal insufficiency. It could be hypovolemia. It could be the effect of medications. But those two, if they are true, will marry into limbic encephalitis and Parkinson's plus syndromes. What if this is subacute meningoencephalitis? Subacute meningoencephalitis is not an uncommon syndrome, unfortunately, and again reflects usually the presence of lymphocytic pleocytosis and mirrors epidemiologically the presence of a subacute infection in the brain. And that is usually mycobacteria and endemic mycoses, but also may mirror the presence of an autoimmune disease like sarcoidosis, or again, a paraneoplastic antibody syndrome. So if we find that the LP is positive, our priority will move away from prion autoimmune psych Parkinson's towards first excluding mycobacteria and fungi. And if we do that, we can move on again to autoimmune and malignant. So I think the next key step is, what is the center of gravity of disease? Is there a systemic signature to this disease process? And what is the LP? With that, we'll be able to paint a picture of isolated CNS dysfunction, either with meningoencephalitis or not, or actually systemic syndrome with CNS inflammation, which will reframe the case. But where are we at now? We're in the subacute cognitive decline world, either rapidly progressive dementia or subacute meningoencephalitis, depending on the LP. The systemic signature will help us prioritize and understand the lay of the land in the brain, and the LP will also help us to which problem we're going to tackle. And with that, I'll hand the mic back to Ori.
Okay. Okay, so labs. So a BMP was normal. He had a baseline creatinine of 1.28. Calcium was normal. LFTs were normal. CBC was notable for a white count of 3.16, a hemoglobin of 10, which was apparently his baseline, an MCV of 81.6, and platelets of 118, which were down from his baseline. The diff was normal. His coags were normal. He had an LP, which was the first LP I ever did, which showed I didn't write down the opening pressure, which was a mistake, but he had a white count of 5, 58% were lymphocytes. Reds were 183 in the first tube and 6 in the last tube. A protein of 362, and a glucose of 100, where the serum glucose was 125. Immediate results from the LP were a meningoencephalitis PCR panel that was normal. Other labs included an ESR and CRP, which were markedly elevated, which I am going to find you the number. So the ESR was about 100, the CRP was around 200. And maybe before we go on, before I hand this back to you, I'm just going to give you a little bit of the hospital course, which will be relevant. Okay, so he was placed on telemetry. He had sinus tach during an episode of hypotension and wobbliness, but there was no other kind of irregularity or arrhythmia. On hospital day 3, he had a headache, and we were concerned for temporal arteritis, so he was empirically given methylprednisone. But in consultation with rheumatology, we had stopped that. We didn't get a biopsy. His orthostatic episodes continued after we stopped his antihypertensives. And then for 5 days in the hospital, he essentially was back to what his daughter called his baseline of the year before. So perhaps we can stop here, or I can give you more. It depends on what you'd like.
Amazing. I know this is super helpful. Okay. Can I just ask, so when you said he's back to his baseline, it's the baseline that he was where he was like perfectly functional, or the baseline before these 5 days of a crisis?
So the daughter said that it was before his first kind of hospital admission the year before.
So it's normalized before your very eyes, huh?
Yes. And then actually, let me give you brain imaging, if that's okay.
Well, sure. Yeah, of course.
Okay. Then
I'll take whatever I can get at this point.
Okay. The non-con head CT was normal. There was no blood. There wasn't significant atrophy. And then the MRI, which was non-contrast, showed a T2 flare hyperintensity in the basal ganglia that was linear and like kind of streaking through the corona radiata and in the basal ganglia.
Got it. And was it on one side or both sides?
It was only on one side.
All right. Whee! Folks, it's getting real hot over here. We have found pancytopenia. Pancytopenia. I was not expecting to find this. Pancytopenia, we actually reflected on yesterday at Thursday's VMR, because on Wednesday, Anne-Marie discussed a case of pancytopenia along with a fantastic crew by her side. And the question is, what is the time course? Why? Pancytopenia comes down to one of 3 things. Either you have a peripheral destruction issue, of which lupus, CLL, and tick-borne diseases are the most common. lupus, CLL, and tick-borne diseases. An issue with something invading the bone marrow, like a lymphoma or a granulomatous infection or a granulomatous disease, or impaired hematopoiesis. The impairment of hematopoiesis can occur as a result of toxic medications like methotrexate and alcohol, of which he's not on any, impaired nutrients like B12 and folate, which are going to be very important to study this case. And the effects of hormone deficiency, so panhypopit can cause pancytopenia. So what is this? This is the pancytopenia, given that the hemoglobin is at baseline 10 and the white count is kind of borderline normal and the systemic signature isn't hectic and acute, the patient hasn't had recurrent infections, hasn't had a lot of bleeding. I think this pancytopenia has been slowly progressive. But it wouldn't stop me from looking at the causes of peripheral destruction, which would be, again, lupus. I think at ANA is definitely in order here. I think tick-borne infections are out the window, and I think CLL is unlikely without lymphocytosis on the peripheral smear. So from the peripheral destruction hypothesis, I think an ANA is in order, but I wouldn't get much more than that. And the question is there impaired hematopoiesis, or is there something invading the bone marrow? There's a case for both. It turns out that impaired hematopoiesis has a lot of overlap with neurological disease. When you think about the causes of impaired hematopoiesis, things like B12 deficiency, folate deficiency, alcohol intoxication, panhypopit, methotrexate, all of them have some sort of neurological signature. So I think impaired hematopoiesis is certainly fair game here, and B12, copper, folate, pituitary hormone levels, and a screen for toxins like heavy metals and alcohol is definitely something to consider. But at the end of the day, are we dealing with a bone marrow process are we dealing with a process that's invading the marrow and affecting the CNS? And it's hard not to worry about a granulomatous disease process, infection, or autoimmune like sarcoid and lymphoma. Lymphoma causing a bone marrow issue is certainly notorious and something that we have to think about. So where does the pancytopenia analysis leaves us? It leaves us reaching for B12, copper, toxin screen, pituitary hormones, and an ANA. And it leaves us worried about lymphoma and a granulomatous disease process, which we probably would hold off on and study the brain before we commit to a biopsy or anything like that. The brain. The finding of a streak in the basal ganglia, to me, actually is well beyond my ability to actually have a robust and thoughtful schema to it. I associate basal ganglia diseases in general with Parkinsonism. I associate them with heavy metal toxicity. I associate them with a lot of metabolic issues like hepatocerebral degeneration, a lot of genetic diseases, which I don't remember and won't consider in a 72-year-old man. But I also associate it with autoimmune encephalitis. So the things that we just, the list that we just named right now, the things like heavy metal toxicity, metabolic diseases like hepatocerebral degeneration or Wilson's disease, metabolic diseases, Parkinson's syndromes, will not have a prominent LP finding. So the LP here tells us there's an inflammatory CNS disease process by the virtue of the protein being so elevated. And what basal ganglia diseases does that map onto? I think it would really highlight the possibility of an autoimmune encephalitis. But I can totally see a subacute to chronic meningoencephalitis like Cryptococcus or TB or endemic mycoses having a focus in the basal ganglia. But to me, I take that as a novice and I say, you know what? I think there's an autoimmune disease process or a malignant disease process. And the problem is the autoimmune disease process may be paraneoplastic, taking us to infection. At the end of the day, I think the most powerful feature of this case is nothing that we talked about so far. How does someone go from a devastating level of confusion to normal so quickly? Is it the steroids? Maybe. That would reinforce the autoimmune hypothesis. Is it intermittent seizures that this person is having? Which is not a hypothesis that's diagnostically very fruitful, because then we'd have to go back and say, well, why is this person seizing anyway? And it takes us back to the analysis we just did. Or is this characteristic of an autoimmune encephalitis like Hashimoto's encephalopathy? That's the crazy thing about some of these autoimmune encephalitides is these patients, Hashimoto's is a controversial encephalopathy. It's now called steroid responsive encephalopathy with myoclonus or something like the other, but it's associated with anti-thyroid hormone antibodies and characteristically has episodes of profound encephalopathy followed by return to normal. So where are we at? I think you'd be most worried about a lymphoma or a granulomatous process, but you'd have to be considering priority in autoimmune encephalitis, but not miss the basics. The basics here are an ANA, nutritional analysis, toxin analysis, and then progress from there. All right, Ori, back to you.
Okay. An ANA was negative. A smear was normal. There were no toxins. B12 was normal. The heavy metals were all normal. His TSH was normal. He was hooked up to EEG, and an episode of this like hypotension wobbliness was captured, and there was no epileptiform activity. On hospital day 7, he began spiking daily fevers. During these fevers, he became more confused. He was tachycardic, hypotensive. On hospital day 12, he developed a new oxygen requirement. He was rigering. He was on requiring 4 liters of nasal cannula. His thrombocytopenia got worse, went down to a nadir of around 70,000. His creatinine increased to 1.6. An LDH was measured that was elevated. And then we got a series of other labs back. So his blood culture, he was pan cultured during these fevers. They were all negative. He had an HIV, which was negative, a VDRL, which was negative. His paraneoplastic panel from his CSF was negative. His TPO antibody was negative. His SPEP revealed no monoclonal gammopathy. A protein electrophoresis from the LP revealed a monoclonal IgM spike, and he had elevated IgG synthesis within the CSF. And perhaps we can stop there.
All right, terrific. So thank you, Ori. I think I'd summarize this by saying that there seems to be an acceleration of the syndrome that is more hectic from an inflammation perspective. And the question is this patient been in the hospital for so long that they've developed something new, or is this part of the takeoff of the current syndrome? And that's hard to tease out in real life, but I think the easy assumption is to say this is just another clue to the story. And so what do we make with fever inflammation? If this inflammation is in fact lasting this long, it's very, very unlikely for it to be something pyogenic. And all the things that cause chronic inflammation, the only things that would leave the patient not devastated and dead right now is possibly Cryptococcus, I think, with a pulmonary focus and an elevated CSF protein, but I really can't think of anything else that would be this hectic at this point. So you move on to autoimmune diseases and you move on to malignancies. And it's hard to invoke an autoimmune disease in a 72-year-old man that has such prominent systemic signatures. And with the elevated monoclonal IgM in the CSF, it's hard for the spotlight not to be on lymphoma. But I'm stopping and checking myself because I think the prominent autoimmune diseases that develop with age are the vasculitides. And so I'm wondering, could this patient actually have some form of a systemic and now CNS tropic vasculitic syndrome? Or is this a malignancy? I think I'd be very hard pressed to find an infection that's compatible with such a hectic endpoint despite being indolent for a year. I only really view vasculitides and sarcoidosis as the autoimmune diseases that would be compatible with this. And I would be most worried about a lymphoma given the monoclonal process we found in the CSF. Now, what liquid process? How do you prioritize that? I think the monoclonal IgM is certainly evocative of IgM disorders and things like Waldenstrom's, though those tend to have a much more prominent systemic signature and are much more readily apparent to the treating provider through a protein gap, through symptoms of hyperviscosity, through palpable organomegaly and lymphadenopathy. though we haven't imaged the viscera, the lack of lymphadenopathy palpable makes you wonder, are you dealing with a hematological malignancy that does not feature lymphadenopathy? And those are essentially the extranodal lymphomas. And the one particular extranodal lymphoma that is hard to find and loves the brain is intravascular lymphoma. And that also is taking the checkbox given its hectic presentation and propensity for an indolent prodromal phase. So where do we summarize now? We now have the patient has taken off in terms of their symptom complex, and it's been too long for any infection that can now take off at the end of it, especially with the results that we have with the LP where there wasn't really any lymphocytic pleocytosis or neutrophilic pleocytosis. The quality check on autoimmunity is to make sure it's not a vasculitic syndrome or sarcoidosis, but the focus really is on now, I think, lymphoma. Any lymphoma under the sun is fair game as long as it's an aggressive one, given what it's doing to the patient. The monoclonal IgM is a clue to that disease process, and many lymphomas are possible, but if you apply the filter and presume that there's no lymphadenopathy because you didn't feel any and there's nothing in the viscera, you'd probably be most worried about intravascular lymphoma and a variety of T-cell lymphomas. Where do you go next? I think, I don't think you can do much more than biopsy the bone marrow unless you see something on PET that is an easier, more amenable target. So I'd be really curious what the bone marrow shows, and have been humbled so many times. And my list of, and I should say, by the way, one other diagnosis you should think about, because it's potentially curable, is Hodgkin's lymphoma. Hodgkin's lymphoma can do a whole rate of devastating things, so, but it would be unusual for it to be so prominently extranodal. But that's where I'm at, and I'm curious what you have next for us.
That's incredible. Okay. The MRA was normal of the brain to look for vasculitis. He had another LP performed, which showed 4 white cells, 57 reds, a protein of 541, and a glucose of 108, which was about at the serum level. A rapid response was called overnight for hypotension, hypoxemia, and a rising lactate. And he was transferred to the ICU. He was put on max pressors. He had an AKI, new transaminitis, and then he unfortunately a decision was made to cap care, and he passed away. So this will be the final aliquot before the diagnosis is revealed. And we were lucky; his family agreed to an autopsy. And what they found was in the autopsy was large B-cell lymphoma tumor cells in blood vessels and capillaries throughout every organ. So throughout the lungs, the heart, the liver, the spleen, the kidneys, and the brain. He had numerous neoplastic cells in the leptomeninges of the brain, and he had a very large and full vessel within the basal ganglia that was essentially full of CD20 positive B cells.
I think, I don't know what to say. I think, you made, with the large B cells and intravascular propensity, you made the diagnosis of intravascular lymphoma, which is a devastating diagnosis, and one that doesn't uncommonly land here. You'll see that the literature on intravascular lymphoma divides it into 2 different types depending on the geographic location of the patient, with patients in the Western Hemisphere having much more a skin, bone marrow, and CNS phenotype, and patients who are located in the Eastern Hemisphere having a much higher rate of Fernand's favorite diagnosis, hemophagocytic lymphohistiocytosis, or HLH. This patient appears to have the bone marrow CNS version of it. And as a one final pearl, there are very few times where you have to do a blind skin biopsy, and when you're worried about intravascular lymphoma, as you saw, Ori told us this was everywhere, and sometimes you can catch this by doing a blind skin biopsy, meaning a skin biopsy in a place without a rash. But I'm humbled. I think it's a powerful lesson in shrewd and very thoughtful diagnostics, but ultimately some diagnoses are very, very hard to make ante-mortem, and this is certainly one of them. I'm curious what your reflections are, Ori.
Well, I'll tell you 2 things. One was that this was the first patient of mine who passed away. So this case has stuck with me. Second thing is that, I don't think there was anything that we could have done to change the course of the disease. The only interesting thing is that, when we thought there was temporal arteritis, I wonder if a temporal artery biopsy would have revealed the diagnosis. It also, everything kind of fit together with the steroids being kind of having this short-lived improvement. I still can't put together the first, like the episode the year prior. It would seem to be too kind of temporally distant for an intravascular B-cell lymphoma that was as aggressive as this was to have been indolent for a year and then kind of become fulminant, but I could be wrong. And the last thing that I'll say is from a management perspective, there were several days after which his creatinine had bumped where we were very hesitant to do a CT with contrast because we were worried about worsening his kidney function. And I think that if we had done that, we would have seen kind of diffuse enhancement and gone for some sort of tissue diagnosis more quickly, and we probably wouldn't have changed anything, but we would have had an antemortem diagnosis. But I cannot believe it how you guys got that. Fernand at 9:37 said intravascular B-cell lymphoma, so that was just incredible.
This is the power of all bringing everyone together, thinking together, and I think the power of the 45 minds on here is absolutely humbling. But the truth is, none of the learning would happen without you and folks like you presenting fantastic cases to us. And what a way to honor the patient. I mean, this is stuck with you. The very first LP you did, it stuck with you, and here you are teaching a very large community, a lot of whom know a lot about intravascular lymphoma, and a lot who are certainly very keen on knowing it more and more. So thank you so much, Rory. It's a delight to meet you. I can't wait to see you in the flesh in a few months. Congrats on matching out here. I think you'll have a fantastic time.
Thanks. Yeah, this was great.
Awesome. And Kiara, please, why don't you take us to the teaching points, please?
Amazing case, Rory. I learned so much from it. Well, let's start with this patient who had episodic symptoms, and Ravi said that in this case, episodic symptoms is a consequence of a subset of things that begin suddenly, probably a TIA, a syncope, renal, or some biliary colic, but nothing so specific right now. Then we understand that this patient had confusion, and we interpret confusion as an altered mental status. So we have at CPS a very great mnemonic of MIST. So M for metabolic, I for infection, and S for structural, all which are confined to brain. However, T, which is toxins, is not specific for brain. So the question then was, how can we make progress after an altered mental status chief complaint? So we have to assess cardiovascular and neuro exams due to the past medical history of this patient. So then we have many neuro concerns, and we try to determine these concerns with the time course for cognitive brain decline. So this was very great because we have a very broad differential diagnosis for cognitive brain decline. If it is chronic, we have to think a very common disease about dementia, more probably due to Alzheimer's disease. If this is subacute, we have to think about a rapidly progressive dementia, and most common is prion diseases like Creutzfeldt-Jacobs or other variants. Also autoimmune encephalitis, vasculitis, or psychiatric disorders like pseudodementia or catatonia, and also Parkinson's plus syndromes. Also another reason for cognitive brain decline is subacute to chronic, which could be a meningoencephalitis, maybe a mycobacteria, some endemic mycosis, and less common sarcoid or any paraneoplastic antibody syndromes. So again, the next question is, how can we make progress? So we have to identify if there are systemic processes going here, and if so, maybe we also have to perform a lumbar puncture, which was done in this case. In labs, we have found that there was pancytopenia, and pancytopenia can have many causes. One of them, peripheral destruction, maybe lupus, CLL, or tick-borne diseases. Also, an infiltration in the bone marrow, like granulomatous diseases again, or any kind of infection, or sarcoid or lymphoma. Also, another cause for pancytopenia is impaired hematopoiesis. This can be mostly caused by drugs that methotrexate, B12 or B9 deficiency that can interfere in this synthesis, or many copper intoxication, or alcohol. Also, then on images, we found that there was a basal ganglia disease, not specific. So Ravi told us every time he hears about a basal ganglia disease, he thinks about Parkinson, heavy metal toxics, metabolic. This could be hepatic cerebral degeneration, and also again autoimmune encephalitis, maybe a paraneoplastic disease that led to an infection. However, if as there was not a prominent lumbar puncture findings in this case, when we have Parkinson or heavy metal poisoning or something, we don't have any lumbar puncture findings. So how can we make progress? Maybe there is one infection, we don't know. So how did we narrow the differential diagnosis in this case? We used the lab's findings, and we were thinking about crypto or autoimmune diseases like vasculitic diseases which develop with age, and this patient was 72 years old. Also sarcoidosis can be a cause of autoimmune encephalitis, and malignancy, because we saw a monoclonal spike of IgG. So we think about lymphoma. Finally, Ravi told us that when we don't find lymphadenopathy in patients, we have to think about hematologic malignancy diseases like intravascular lymphoma, which is difficult to find because there is no like systemic or concerns like that in physical exam, or maybe T-cell lymphoma. So how do we make progress? In this case, biopsy this patient. Unfortunately, this patient passed away, but well, you were able to do an autopsy and find the final diagnosis. Thank you so much, Ari.
Kiara, that was absolutely majestic. I think this is one of the hardest cases to put teaching points together for, and I think you did a marvelous job. And you can see how I just love how you have them bolded and laid out here for people to look at them later. Ori, thank you so much. Thank you for everyone who joined us, and we'll hope to see you all around every day this week. Take care.